Over the past several weeks, there's been a lot of discussion about the changes to U.S. vaccine policy. Much of that discussion has been oversimplified. Being a pharmacist and advocating for evidence-based care, I'm a firm believer that vaccines are both safe and effective. I will continue to get vaccinated, and I will continue to counsel my patients to get vaccinated. Let's walk through some of the changes that occurred recently, what the evidence is supporting, where debate exists, and where uncertainty remains. In early January, the U.S. Department of Health and Human Services, together with the CDC, completed a review of the U.S. childhood immunization schedule. Now, it's important to understand that this was not framed as being triggered by any new identified safety concerns. It was driven by three factors: comparison with vaccine schedules in developed countries, stagnating or declining vaccination rates, and a documented decline in public trust in healthcare institutions between the years of 2020 and 2024. Their stated goal was to assess whether the U.S. should maintain strong protection while improving clarity, adherence, and trust. Now, it's critical to start with what did not change. Core childhood vaccines remain recommended and fully covered without cost sharing. Now, this includes protection against measles, mumps, rubella, polio, diphtheria, tetanus, HIV, pneumococcal disease, varicella, and HPV. No vaccines were removed from availability, and the HHS states that coverage continues without cost sharing, though several vaccines were reclassified away from the universal recommendation. That point has been lost in much of the public conversation. What changed was the structure of recommendations. Vaccines are now emphasized across three categories. 1, vaccines recommended for all children. 2, vaccines recommended for specific high-risk populations. And 3, vaccines guided by shared clinical decision-making. This framework, you have to understand, itself is not new. Shared decision-making has existed in immunization guidance for years. The difference is the expanded use of this approach and the increased emphasis on individualized risk discussions. Now, this is where the evidence becomes less clear. The decision to reclassify some vaccines from universal recommendation into risk-based or shared decision-making categories was supported primarily by international comparisons and public trust considerations. However, multiple professional organizations and public health experts noted that no new clinical evidence was present showing reduced safety or effectiveness of these vaccines when used routinely. So while reorganizing guidance may help communication, the evidence base for downgrading long-standing routine recommendations remains contested. This aspect of the policy is widely expected to remain under review and debate. The HPV vaccine, it was updated on firmer scientific ground. Long-term randomized trials, most notably a study led by the National Cancer Institute with nearly 20 years of follow-up, found that a single dose of HPV vaccine in younger adolescents provided protection against HPV 16 and 18 comparable to 2 doses. Now, these findings have been replicated internationally and informed the WHO or WHO support for a single-dose HPV strategy in adolescents. So based on this evidence, US guidance now recommends 1 dose for 11 and 12-year-olds. This recommendation applies to younger adolescents, but guidance may differ by age and immune status. With that being said, some uncertainty remains. FDA labeling still reflects the multi-dose schedules, and the policy shift occurred faster than traditional advisory processes, which has raised concerns about implementation rather than the existence of supporting the data. The clearest example of evidence-aligned change was the cervical cancer screening. Updated federal guidelines now prioritize high-risk HPV testing every 5 years for adults aged 30 to 65, including those self-approved collection options. Multiple studies show HPV testing is more sensitive than cytology alone, and self-collection significantly improves screening rates, especially in underserved populations. This update aligns closely with recommendations from major cancer and preventative care organizations. When we take a step back, the picture looks like this. Some changes like HPV dose reduction and screening modernization are supported by strong and growing evidence. Other changes, particularly the reclassification of some routine childhood vaccines, are more controversial and not clearly driven by new clinical data. The key moving forward is continued evaluation by clearly separating what we know, what appears promising, and what still requires careful study. I'd love to know your thoughts on this. Drop them in the comments section below and let's have a conversation.